Welcome back to the Deep Dive. Today, we are going to do something a little bit different. We're going to take a word that I guarantee every single person listening has used probably in the last month. And we are going to just completely dismantle it. The word is bipolar. And, I'll be the first to admit, before I really dug into this material, I was so guilty of the casual usage.
Oh, everyone is.
Everyone is, right? You know the drill. The weather is so bipolar today, or my boss is totally bipolar. He changed his mind about the project 3 times. We use it as this shorthand for moody or indecisive or just changing.
It is arguably the most colloquially misused clinical term in the English language right now. It really is.
Is it? More than OCD?
It's up there. It's definitely in the top 2. It's right up there with OCD for how much the public perception has just drifted away from the medical reality. But when you actually open the books, and for us today, that's chapter 67 of this comprehensive medical text we're analyzing, you realize that the gap between I'm moody and I have bipolar disorder is not just a gap, it's a canyon.
That is exactly what we are here to do. We are going to try and bridge that canyon. This isn't just about mood swings. We are talking about a complex biological systemic condition that affects everything from your sleep cycle all the way to your kidney function.
Right.
And for our listeners today, and I know we have a lot of learners out there, maybe you're a med student cramming for boards, or maybe you have a family member who just got diagnosed and you're trying to make sense of all the jargon. This is for you. We are going to unpack the pathophysiology, the very distinct types of episodes, the absolute alphabet soup of medications, and the really critical role of lifestyle.
And we're going to do it by connecting the dots. That's my goal for us today. I don't want to just, list symptoms. Anyone can read a list off a website.
Right.
I want us to understand why the symptoms happen. Why does a salt, like lithium, literally an element from the periodic table, stop suicide? Why does staying awake all night trigger a manic episode? When you understand the biology, the actual mechanics of the brain misfiring, the treatment starts to make sense.
It's not just random.
It stops being a random list of pills and starts looking like a strategic engineering fix for a biological problem. It's logical.
And looking at our source material here, it really is a strategic fix, but it's complicated. I was looking at the drug algorithms in this chapter, and it felt like I needed a degree in chemistry just to read the table of contents. I mean, we've got anticonvulsants, antipsychotics, salts, interactions. It's heavy stuff.
It is heavy, but it's manageable if we break it down piece by piece. And that's really the key theme for today, management through knowledge. The text is very, very clear that adherence, just sticking to the plan, is the #1 factor in success.
The most important thing.
The most important. But you can't stick to a plan if you don't respect the disease. And you can't respect the disease if you don't understand it.
So let's start at the very bedrock, the definition, Section 1. What actually is bipolar disorder? I think the first place people get tripped up is the difference between bipolar I and bipolar II. I always assumed, pretty ignorantly, that bipolar I was the mild version and II was the intense version, or maybe vice versa, like a ranking system. But that's not it at all, is it?
No, and that is a very common misconception. It's not a hierarchy of severity. It's a distinction based on the nature of the high. That is the absolute core differentiator.
The nature of the high.
To be diagnosed with bipolar I, the clinical guideline is absolute. You must have had at least one manic episode, full stop.
Hey, wait, pause there. Just one.
Yeah.
In a whole lifetime, that's all it takes.
Just one. This is a crucial concept. Let me paint a picture for you. You could be 45 years old. You could have struggled with crushing depression for 20 years, on and off. But if, when you were 22, you had one singular week where you didn't sleep, thought you were a prophet, and drained your entire bank account, that puts you in the bipolar I bucket forever.
Wow.
Even if you never have another manic episode again. That 1 week, 20 years ago, changes the diagnosis and the entire treatment plan permanently.
That is wild. So bipolar I is anchored completely by the presence of mania. So then what about bipolar II?
Bipolar II is different. To get that diagnosis, you need 2 things to be true. You need at least 1 episode of hypomania, which is a distinct, less severe form of mania we'll get into, and a current or past history of major depression.
Oh, so for bipolar II, the depression is actually a required part of the criteria.
Exactly. For bipolar I, technically, you don't even need to have had a depressive episode to get the diagnosis, though almost everyone does. The entire diagnosis of bipolar I hinges on the mania.
Okay, so to really understand this, we need to understand the episodes. Mania is another one of those words we just throw around, Manic Monday, right? But clinical mania, reading this chapter, It sounds terrifying.
It's a medical emergency. It's not a mood. The text defines a manic episode as lasting at least 1 week or, and this is key, being severe enough to require hospitalization. And the phrase you need to just underline in your mind is marked impairment.
Marked impairment.
This isn't just having a great week where you're crushing it at work and feeling on top of the world. This is blowing up your life.
Let's look at the symptoms in the text. The first one is grandiosity. This isn't just confidence, right?
Oh, not even close. Confidence is thinking you can get the promotion at work.
Right.
Grandiosity is thinking you have been chosen by God to rewrite the Bible, or that you have a secret plan to solve the national debt by Tuesday. It is delusional self-esteem. It's a complete break from what's possible.
And then there's the sleep. This seems to be the most consistent red flag in all the literature. Decreased need for sleep.
And we have to be so careful to distinguish this from insomnia. In insomnia, you're lying in bed, you're staring at the ceiling, you were desperate to sleep, and the next day you are wrecked. You're exhausted, you're dragged.
You feel terrible.
Awful. In mania, you might sleep 2 hours or maybe 0 hours, and you wake up feeling like you just chugged 5 espressos. You are fully charged. The battery isn't just full, it's overfilling. You feel fantastic.
And all that energy has to go somewhere. The text mentions flight of ideas and pressure of speech. What does that actually look like in a person?
Think of a pressure cooker. The brain is generating thoughts faster than the mouth can physically form the words to get them out. That's flight of ideas. The channel is changing every 2 seconds. A person might be talking about their dog, then a political theory, then a memory from childhood, all in one sentence with no logical connection.
So you can't even follow their train of
Well,
thought.
there is no train. It's just sparks. And pressure of speech is exactly what it sounds like. It's loud, it's fast, and it is uninterruptible. If you are talking to someone in a manic state, you feel like you are standing in front of a fire hose of words. You literally cannot get a word in edgewise.
And then, of course, the part that leads to the hospitalization, the destruction, the risky behavior. The text uses this very clinical phrase, excessive involvement in activities that have a high potential for painful consequences.
That is the clinical, polite way of saying they destroy their lives. Buying sprees are classic, spending the family's life savings on 3 luxury cars in a single weekend. Sexual indiscretions, having affairs that are completely out of character for the person with no regard for the consequences.
Foolish business investments, gambling.
All of it. The part of the brain that says, hold on, maybe this is a bad idea, your frontal lobe, the brakes, are effectively cut. There is no impulse control. And in the most severe cases of bipolar A, you can have full-blown psychosis, hallucinations, paranoia. You lose touch with reality entirely.
Okay, so that is mania. That's the anchor for bipolar way. Now let's dial it back to hypomania. Hypo meaning under or less than. So under mania, this is the marker for bipolar 2. The text says this lasts at least 4 days.
Right. And on the surface, it looks very similar to mania. You have the high energy, the decreased need for sleep, the racing thoughts, the charm, the talkativeness. But, and this is the but that defines the entire diagnosis, there is no marked impairment in functioning, no hospitalization, no psychosis.
See, this is the tricky part. This is the part I get stuck on. If there's no impairment and you just feel energetic and confident and creative, that sounds kind of amazing. Why is that a disorder?
And that is the trap. That's the seductive nature of it. It's often called the CEO's disease in this phase because people can be incredibly productive. They work 18-hour days. They are charismatic. They close deals. They get things done. Their colleagues might just think they're on a hot streak.
But there are problems.
There are 2 massive problems. First, the text notes that for about 5 to 15% of these patients, the hypomania is not a stable state. It's a gateway drug to full-blown mania. It's unstable ground, and you don't know if you're about to fall off the cliff.
And the second problem.
The crash. Bipolar 2 is defined by the oscillating nature. The up has to be paid for by a down. The hypomania might last 4 days, but it is almost inevitably followed by a major depressive episode. And the depression pays the bill, with interest, for the energy you borrowed.
Let's talk about that depression. Because I think we tend to stereotype bipolar as the happy, crazy disease and depression as the sad disease. But the text makes a really, really disturbing point here. It says that psychotic features, delusions, hallucinations, and suicide attempts are actually more common in bipolar depression than in regular unipolar depression.
It is a staggering fact, isn't it? It completely upends the common perception. The lows of bipolar are often biologically deeper and more severe than the lows of straight major depression. The biological dysregulation is just more profound.
And the symptoms can be different, too.
Very different. The text calls them atypical. In regular depression, you often see insomnia and weight loss. In bipolar depression, it's often the opposite. You see hypersomnia, sleeping 14, 16 hours a day and still feeling exhausted, and something called leaden paralysis.
Leaden paralysis.
Patients describe it as their limbs physically feeling like they're made of lead. It's a physical effort just to lift an arm to drink a glass of water. It's a profound, heavy physical exhaustion on top of the emotional pain.
So you have bipolar I with the high highs, bipolar II with the subtle highs and the crushing lows, and then you have the mixed episode. Reading the description of this, it sounds like the absolute worst-case scenario.
It is arguably the most volatile and dangerous state in all of psychiatry. The clinical criteria require symptoms of both mania and depression occurring nearly every day for at least a week.
I'm trying to visualize that.
Yeah.
How can you be manic and depressed at the same time? It seems like a contradiction.
It's what we call a dysphoric mania. Imagine having the engine of mania, the agitation, the racing thoughts, the physical energy, the inability to sit still, but the emotional content of those racing thoughts is pure despair, guilt, and self-hatred.
Oh, wow.
So in a pure depression, you might have suicidal thoughts, but you're too exhausted and apathetic to get out of bed to act on them. In a mixed episode, you have the intense desire to die, and you have the boundless manic energy to execute the plan.
So the risk.
The suicide risk is astronomical in this specific state. It's the most dangerous combination possible.
That is a terrifying combination. Okay, so we have the what. I think we have a much clearer picture of what these states look like. Now I want to understand the why. Section 2, Pathophysiology. The text is clear that it's not just one thing. It's not just you have the bipolar gene and you're doomed.
Yeah, but it is profoundly multifactorial. We know there is a huge genetic component. The heritability is estimated at over 80%, which is massive. For comparison, that's higher than the heritability for most cancers or heart disease.
80%.
It's huge, and it likely involves multiple gene loci, not just one single switch. But the genes are just the loaded gun. The environment, your life, your biology, that's what pulls the trigger.
And this leads us to one of the most fascinating parts of the text for me. There's this whole table 67.1, on secondary causes of mania. This is the House MD part of the deep dive. The text lists a whole bunch of things that can look exactly like bipolar disorder, but are actually something else entirely.
This is why you cannot and should not diagnose bipolar with a BuzzFeed quiz. You need a medical doctor, you need a full workup. Because if someone comes into the ER acting manic, the first job is to rule out all these other organic causes.
Like what the text lists brain tumors. That seems so dramatic.
It is, but it happens. Brain tumors, specifically in the frontal lobes or temporal lobes, can cause disinhibition and personality changes that look exactly like mania. Multiple sclerosis as well. The lesions in the brain can disrupt mood circuits. And endocrine issues, this is a big one.
The thyroid.
Hyperthyroidism. If your thyroid is pumping out way too much hormone, your whole body is in overdrive. You will be agitated, you won't sleep, you'll have racing thoughts, your heart will pound. If you give that patient lithium, you aren't fixing the problem. You need to treat the thyroid.
And electrolytes. This one really surprised me. Things like calcium and sodium.
The brain is an electrochemical machine. It runs on ions, on salts moving across membranes. It's pure electricity. If you have, say, hypercalcemia, too much calcium, or hyponatremia, not enough sodium, your neurons start misfiring. It can absolutely present as psychosis or mania.
Then we get to the substances.
Yeah.
We know about the obvious ones, cocaine and meth, they're stimulants. But the text lists everyday items. It starts with caffeine.
Yes, xanthines. That's the chemical class for caffeine and theobromine in chocolate. In a neurotypical brain, a triple espresso makes you jittery and anxious. In a brain that is genetically predisposed to bipolar, a very high dose of caffeine can be enough to destabilize that fragile mood regulation system and actually trigger a hypomanic or manic episode.
And herbal products.
Yeah.
I see St. John's wort at the grocery store all the time, marketed for mood support.
And for someone with unipolar depression, it can sometimes help. But for someone with an undiagnosed bipolar disorder, it is incredibly dangerous. St. John's wort acts very similarly to a mild antidepressant. And this brings us to the supreme irony that the text highlights in bold. Antidepressants can induce mania.
This is the switching phenomenon you hear about. Can you explain how that works mechanically?
Think of the mood regulation system as an elevator in a building. In depression, the elevator is stuck in the basement. You give an antidepressant, an SSRI like Prozac, for example, to push the button to go up. In a normal brain, the elevator goes up and it stops at the ground floor, which is normal mood or euthymia.
Okay.
In a bipolar brain, the braking mechanism for that elevator is faulty. So the antidepressant pushes the button to go up, the elevator hits the ground floor, doesn't stop, and rockets right through the roof into mania.
That is a fantastic analogy. So the drug that is supposed to help actually flips the polarity of the illness.
It does. It reveals the underlying bipolarity, which is why any good clinician, when they see a patient for depression, has to ask, have you ever had a period where you felt the opposite of this, where you had tons of energy and didn't need to sleep? If you miss that history and just give them an antidepressant, you can cause a manic episode.
The text also mentions somatic therapies as triggers, and one of them is sleep deprivation.
Sleep is a massive theme in this chapter. We touched on it as a symptom, but it is also a powerful trigger. Sleep deprivation is so potent at inducing mania that in research settings, they can reliably trigger it just by keeping a vulnerable patient awake all night.
So it's not a coincidence.
It's causal.
Yeah.
It completely disrupts the circadian rhythm, the body's internal clock. The brain doesn't know what to do, and the mood system just breaks.
So for a college student with bipolar disorder, pulling an all-nighter for finals isn't just tiring, it's physically dangerous.
It is pouring gasoline on a potential fire. It's one of the biggest risk factors for relapse. Shift work, jet lag, all-nighters, these have to be managed so carefully.
Let's move to section 3, the roller coaster, the course of the illness. We've established it's biological, we've established what can trigger it, but who gets it, and how does it play out over a lifetime?
It usually starts young. The classic onset is late adolescence, early adulthood. That late teens to mid-20s window is the highest risk period.
Is there a gender difference?
For bipolar MA, it's pretty evenly split between men and women. But the presentation often differs, which I find fascinating. The text points this out.
It says here women are more likely to have depressive symptoms, a later age of onset, and they also have more comorbid thyroid abnormalities.
Right. Which can complicate the picture. Whereas men are more likely to present with mania first and, this is a crucial point, have much higher rates of comorbid substance use.
Which has to make diagnosis a nightmare. Is he manic or is he high on cocaine? Is he depressed or is he in alcohol withdrawal?
Or is it all of the above? Often patients use substances to try to sedate the mania, maybe with alcohol or benzodiazepines, or they use stimulants like cocaine to try to lift themselves out of the depression. It's a form of self-medication that just makes the underlying condition 10 times harder to treat.
There is a term in this section I really want to clarify because, again, people use it wrong all the time. Rapid cycling.
Yes. This is a big one. People think rapid cycling means I was happy at breakfast and then I got angry at lunch. That is usually not bipolar. That's more likely emotional dysregulation or maybe something like borderline personality disorder.
Okay, so what is the clinical definition?
True rapid cycling has a very strict clinical definition. 4 or more distinct mood episodes in a single year. That could be any combination, mania, hypomania, depression, or mixed states.
Only 4. That's the cutoff.
4 is the cutoff. And I know it might not sound like a lot, but imagine going through a month of major depression where you can't get out of bed, recovering from that, then going into a life-destroying manic episode for a week, recovering from that, and then doing that whole cycle one more time, all inside of 12 months.
It's exhausting just thinking about it.
It is absolutely exhausting for the patient and their family. It affects about 20% of patients, and the text is clear that it is associated with a much poorer long-term prognosis. It is just harder to stabilize because the therapeutic target is constantly moving.
And now we have to talk about the stakes. The text does not shy away from the mortality data, and honestly, reading it, it is terrifying.
It is incredibly sobering. We often talk about mental health in terms of quality of life, but for bipolar disorder, we are talking about life itself. The text states that suicide attempts occur in up to 50% of patients.
Half. 1 in 2 patients will attempt suicide at some point.
1 in 2. And the completion rate is devastating.
What's the number?
For bipolar I specifically, the text says 10 to 19% of individuals eventually die by suicide. Let's take the middle of that. That's 1 in 7. It is one of the highest mortality rates of any psychiatric condition by far.
And the text points out when this happens. It's not random.
No, it's very specific. The attempts are primarily associated with the depressive episodes and, as we talked about, the mixed episodes. This is why we cannot just focus on controlling the crazy mania. That's the stereotype. We have to aggressively treat the depression because the depression is what kills people.
Which leads us directly into the solution. Section 4. The treatment landscape. This is really the meat of the chapter. We've got the big three categories: lithium, anticonvulsants, and antipsychotics.
And before we dive into the specific drugs, we need to frame the overall strategy. The text makes a clear distinction between acute treatment, just putting out the fire that's burning right now, and maintenance treatment, which is fireproofing the house so it doesn't burn down again.
And the golden rule over all of it.
The absolute non-negotiable factor that the text mentions again and again is adherence.
Adherence is the most important factor, but it's also got to be the hardest, isn't it?
It is incredibly, incredibly difficult. Try to put yourself in the patient's shoes. When you are manic, you don't feel sick. You feel like a god. You have boundless energy. You are funny. You are brilliant. You are the life of the party.
You feel better than well.
Better than well. Then the doctor gives you a pill that takes that away and makes you feel normal. And maybe that normal feels a little flat in comparison. And maybe the pill makes you a little thirsty or gives you a tremor. You miss the high. It's very tempting to stop the pill. And then the cycle starts all over again.
Okay, let's talk about the pills. Category 1, the legend, lithium.
Lithium is in a class of its own. It's not a big, fancy molecule synthesized in a lab. It's an element. Number 3 on the periodic table. It's a salt found in the earth, found in our drinking water in tiny amounts. And yet, it remains the absolute gold standard for treating classic euphoric mania.
And the text mentions a specific statistic that sets it completely apart from every other drug: the suicide reduction.
This is lithium's superpower. It is the only mood stabilizer that has been consistently shown to have a specific anti-suicidal property independent of its mood-stabilizing property. It reduces the risk of suicide by 8 to 10-fold.
8 to 10 times.
It's a massive effect. No other psychiatric drug has that level of proven anti-suicidal benefit. We don't even fully know why it works so well, but the data is undeniable.
But dealing with lithium is tricky. It's not like taking a Tylenol. The text talks a lot about the narrow therapeutic window.
It is incredibly narrow, one of the narrowest in all of medicine. We aim for a blood level between 0.6 and 1.2 milliequivalents per liter. If you are at 1.0, you are in the perfect zone. If you drift up to 1.5, you're starting to get toxic. At 2.0, you are in a medical emergency. You are poisoning yourself.
And this is where the biology gets so fascinating, because the text explains that because it's a salt, the body basically thinks it's sodium.
Exactly. Your body doesn't really have a lithium receptor. It handles it like it handles sodium. Think of your kidneys as a bouncer at a nightclub. The bouncer's main job is to manage the sodium level to control blood pressure and fluid balance. He knows what sodium looks like.
Okay.
But lithium puts on a fake mustache and a trench coat, and it looks almost exactly like sodium. The bouncer at the kidney can't really tell them apart.
So what happens if you get dehydrated? Say you get the stomach flu, or you run a marathon in the summer.
If you get dehydrated, your body panics. It sends a message to the kidney bouncer. Hey, don't let any sodium leave the club. We need to hold on to every last drop of water. So the kidney starts reabsorbing all the sodium it can. But because it can't tell the difference, it also reabsorbs all the lithium.
So your blood levels of lithium can skyrocket.
They can double or triple, not because you took more pills, but because you didn't drink enough water. You can become toxic very, very quickly.
So the big takeaway for anyone on lithium is you absolutely cannot go on a low-salt diet, and you have to stay consistently hydrated.
Correct, on both counts. A low-salt diet will tell the kidneys to hoard sodium, and therefore lithium, raising your levels. Taking NSAIDs like ibuprofen or naproxen does the same thing. It restricts blood flow to the kidneys and raises lithium levels. You have to be incredibly consistent with your salt and water intake.
What about the common side effects, even when you're not toxic? The text mentions nephrogenic diabetes insipidus. That sounds incredibly scary.
It sounds worse than it is, but it is very, very bothersome for patients. The diabetes part here has nothing to do with blood sugar. It just uses the old Greek word for siphon, meaning passing a lot of fluid.
Okay.
Basically, lithium makes the kidneys less responsive to the hormone that tells them to concentrate urine. So the kidneys just let water pass right through.
So you're just peeing clear water all day.
Constantly. The official term is polyuria. Some patients pass more than 3 liters of urine a day, and because they are losing so much water, they have polydipsia, an extreme unquenchable thirst. It's a vicious cycle.
And the tremors. The chapter says that happens in up to half of patients.
A fine hand tremor, yes. It's very common. For most people, it's just an annoyance. But imagine you're a surgeon or a dentist or a musician or an artist. It can be a deal breaker for your career.
Wow. Okay, let's move to category 2, anticonvulsants. These are epilepsy drugs. Why are we using seizure meds for a mood disorder? What's the connection?
It actually makes perfect sense when you think about the brain in terms of electricity. What is a seizure? It's an electrical storm, a synchronized, uncontrolled, hyperexcitable firing of neurons.
Misfiring.
And what is mania? It's a very similar state of biological noise and hyperexcitability. The brain's activity is out of control. These drugs, these anticonvulsants, work by calming that electrical excitability. They essentially raise the threshold for the neurons to fire, making the brain less excitable. They stabilize the membranes.
The big one here, the text says, is valproate or DiPiro.
Valproate is the workhorse. The text says it is the most prescribed mood stabilizer in the U.S., even more than lithium, and it's particularly good for certain types of bipolar that lithium doesn't work as well for. It's actually better than lithium for irritable mania.
That's the angry mania you mentioned before.
Exactly. Not the euphoric, I'm Jesus and I can fly mania, but the agitated, irritable, everyone is an idiot and is in my way mania. Valproate is excellent for that. It's also better for mixed states and for rapid cycling.
But the side effects, I'm looking at the list. Hair loss.
Alopecia, yes. It's usually temporary and can sometimes be managed with supplements, but it happens and it can be very distressing. And weight gain is very common, which can be a real problem for adherence. But the scary ones are the internal ones, pancreatitis and, very rarely, fatal hepatotoxicity liver damage. You have to monitor blood work regularly.
Then we have carbamazepine. This one seemed pharmacologically the most complicated to manage. The text talks about something called autoinduction.
This is a wild pharmacological concept. It's fascinating. Think of your liver enzymes as a crew of little Pac-Men. Their job is to chew up and metabolize drugs to get them out of your system.
Okay, got it.
When you first take carbamazepine, the existing crew of Pac-Men eats it at a normal speed. But carbamazepine is sneaky. It actually sends a signal to the liver to manufacture more Pac-Men.
So the liver gets better and better at eating the drug.
Exactly. It revs up its own metabolism. So you might be on a steady dose that gives you a perfect blood level on week 1, but by week 4, your liver has so many new Pac-Men that it's eating the drug so fast that the level in your blood drops to near 0. You have to keep increasing the dose for the first month just to stay in the same place.
And I'm guessing these super Pac-Men don't just eat carbamazepine, right? They eat other drugs too.
They do, and this is a critical safety issue. Carbamazepine induces the metabolism of many other drugs, including oral contraceptives. It eats the hormones in the birth control pill before they have a chance to work.
So a woman on this drug might think she is protected from pregnancy, but the pill is completely ineffective.
100%. She could get pregnant while taking a drug that is known to cause birth defects. It's a massive safety flag that requires a lot of patient education.
Speaking of SASI, there's a major genetic warning here for people of Asian ancestry.
The HLA-B1502 allele, it's a genetic marker that is found much more commonly in people of Asian descent. If you have this gene and you take carbamazepine, your immune system can mount a catastrophic attack on your own skin. It causes Stevens-Johnson syndrome, or SJS.
What is that?
It's a horrific reaction where the skin and mucous membranes blister and peel off as if you've been severely burned. It can be fatal. Because the risk is so high in this population, genetic testing for this allele is mandatory before starting the drug.
That brings us to the third big anticonvulsant, lamotrigine or Lamictal. I labeled this one in my notes as the maintenance hero.
That's a great way to put it. It is the hero for the low side of the illness. Lamotrigine is not very good for stopping an acute manic episode that's already happening, but it is fantastic at preventing future depressive episodes. For many patients, it keeps the floor from falling out from under them.
But it also carries the same rash risk, SJS.
It does, which is why the text emphasizes the dosing mantra. Low and slow. You have to start with a tiny baby dose, like 25 milligrams, and titrate up incredibly slowly over weeks. If you rush it, you dramatically increase the risk of that dangerous rash.
And there is a specific drug interaction here that caught my eye. It seems really important. If you take lamotrigine with valproate...
This is the classic pharmacy school exam question. Valproate strongly inhibits the metabolism of lamotrigine.
So it does the opposite of the Pac-Man thing.
Exactly right. Valproate basically ties up the Pac-Man that eats lamotrigine. So if you're taking lamotrigine and you add valproate, the lamotrigine has nowhere to go. Its levels in the blood can double.
So you have to cut the dose.
You have to cut the lamotrigine dose in half immediately, or you risk toxicity and the deadly rash.
It really is a chemistry set.
Yeah.
You can't just throw these pills at the problem. You have to understand how they all interact. Which brings us to category 3, antipsychotics, Drugs like olanzapine, quetiapine, or aripiprazole.
These are the heavy hitters for the acute phase. They are the firefighters. Lithium can take a week or more to really kick in. Valproate takes several days. If you have a patient who is manic and tearing up the emergency room, you need something that works now.
And these work quickly.
Antipsychotics can start working in hours. They primarily work by blocking dopamine receptors, which dials down the mania and psychosis very, very fast. They are often used in combination with lithium or valproate for a synergistic effect during those acute episodes.
So why not just keep everyone on them long term? They sound effective.
Because of the long-term price, the text is very clear about the risk of metabolic syndrome, significant weight gain, increased risk of type 2 diabetes, high cholesterol, high triglycerides. They can have a heavy physical toll over the years. And there's also the risk of tardive dyskinesia, a potentially permanent movement disorder. So it's a trade-off.
Okay, we are entering the home stretch here, Section 5. Special populations and holistic management. We touched on pregnancy risks with the birth control issue, but the text is very specific about the teratogenic risks of these drugs.
This is one of the hardest conversations in all of psychiatry. You have a woman with severe bipolar disorder who is stable on her medication, and she wants to be a mother. What do you do?
Because the drugs are risky for the baby.
They are. The text notes that lithium is associated with a rare heart defect called Epstein anomaly in the fetus. Valproate is even worse. It's associated with neural tube defects like spina bifida in about 5% of cases.
5%. That's a 1 in 20 risk. That is incredibly high.
It's a huge risk. Carbamazepine also carries a risk of neural tube defects, though lower, around 0.5 to 1%. It's a terrible dilemma.
So do they have to stop the meds to get pregnant?
That's the impossible choice. Because if they stop the meds, the risk of relapse is enormous. And the text notes that the postpartum period right after delivery is the single highest risk time for relapse in a woman's entire life. The hormones crash, the sleep is completely disrupted by the newborn. It is a perfect storm for a severe manic or depressive episode.
So the guideline is often to restart the meds immediately after delivery.
Yes. Often prophylaxis is recommended, starting the medication right after she gives birth to prevent that postpartum relapse, which can be devastating.
Finally, let's talk about lifestyle as medicine. This isn't just the doctor telling you to eat your veggies. The text frames these lifestyle changes as a non-negotiable part of the treatment algorithm.
They are part of the prescription. We've already established that sleep deprivation triggers mania. So a regular sleep-wake schedule is not optional. It is medicine. You have to protect your circadian rhythm like your life depends on it, because it does.
And things like diet and exercise.
Absolutely. Regular nutrition, avoiding processed foods and sugar spikes, and consistent exercise, which is a known antidepressant and mood stabilizer in its own right. And then there's therapy, like cognitive behavioral therapy, to help manage stress and identify early warning signs.
And the text really emphasizes involving family members.
This is so crucial. The patient is often the last person to realize they're becoming hypomanic or manic. To them, they just feel good. They have what's called poor insight.
So they don't see it coming.
They don't. You need a spouse or a parent or a close friend who knows the signs. The person who can say, hey, you're talking a little fast today, or hey, I noticed you bought 3 expensive guitars yesterday. What's going on? That external feedback loop is an essential safety net.
So we have unpacked the definitions, the biology, the roller coaster course, the massive drug menu, and the lifestyle factors.
Yeah.
It's a lot.
It is. But if we synthesize this whole deep dive, the central message is that bipolar disorder is a manageable, lifelong medical condition. It requires a cocktail approach. It's never just one thing. It's medication plus lifestyle plus therapy plus vigilance. The text outlines these treatment algorithms. If drug A fails, you try drug B or you combine A plus B. It takes patience and partnership with your doctor.
I want to leave our listeners with one final, slightly provocative thought that I pulled from reading this chapter. In the course of illness section, it mentioned that early onset and rapid cycling lead to a poorer prognosis. And it implies a concept that isn't explicitly named but is well known in the field. Kindling.
Yes. This is a very powerful theory, and it's actually borrowed from epilepsy research.
Right. The idea is that every seizure a person has makes their brain more susceptible to having another seizure. It's like starting a fire. The first time, you need a lot of dry wood and maybe some lighter fluid. But once the fire's burned a path, it catches much more easily the next time.
That's a perfect analogy. The kindling theory suggests that mood episodes themselves are neurotoxic. They damage the brain. Every manic or depressive episode carves a deeper groove, making it easier and more likely for the brain to slide back into chaos the next time. The episodes can start to happen more frequently and with less of a trigger.
Which really underlines the critical importance of staying on treatment. Taking the meds isn't just about feeling better today. It's about protecting your brain's future. It's about preventing that fire from burning the past any deeper.
That is the most powerful takeaway from all of this. Treatment is neuroprotection. Adherence isn't just about managing symptoms, it's about preserving brain health over a lifetime.
Thank you so much for walking us through this.
Yeah.
This was heavy, but so necessary and so incredibly clear. To our listeners, thanks for diving deep with us.
Stay curious.